Okay, so these are for the steps of the phacoemulsification. I hope that the last part was enjoying for you. Let's now come to for maybe less more theoretical part, which is the intraoperative complications. Okay, Dr. Hager is asking what is the surge? Surge meaning that so I didn't I will send it to you in the WhatsApp group a lecture for me for discussion of phaco-dynamics. Phaco-dynamics is a little bit outside the scope of this exam, and I didn't try to go through this area because it will take a lot of time, and we will lose valuable time during the surgery. So it is already pre-recorded from my previous talks in some conferences and some educational activities. I'm going to send you the links in the lecture, so or in the WhatsApp group, so you will understand more about what's phaco-dynamics. Again, Dr. Rufaida, the machine settings will be a part of the phaco-dynamics. I will share you to the group because it will be difficult to discuss it without slides, and it will take a lot of time, and we still have a lot to explain regarding the intra and post-operative complications. Okay, let's move to the intraoperative and postoperative complications. Regarding the intraoperative complications, we have the wound-related complications such as iris prolapse, corneal complications such as isthmus membrane detachment and corneal burn, anterior chamber detachment, anterior chamber complications like iridodialysis, flattening of the anterior chamber, hyphema, intraoperative floppy iris syndrome, lens-related complications such as dropped lens, retained lens matter, and posterior loss of the lens fragment. IOL-related, it is IOL dislocation. Posterior chamber such as the posterior capsular rupture or PCR, cyclodialysis, suprachoroidal effusion, and hemorrhage. Okay, let's start first by the wound complications. What are the wound complications that may happen if there is poor construction of the wound? If the wound is too posterior or too limbal and it is too short, this will result in what's called iris prolapse. So the iris will keep coming out from the wound every now and then because of the poor wound construction. So in this case, you may need to use the iris dilators or to dilate the iris and to try to sweep the iris, but not from the main wound like that, because this will make the iris more suicidal, more tend to get out of the wound, but you just sweep the iris from the iris root and or from the paracentesis, and always make sure that there is no high intraocular pressure. So this can be sometimes exerted by much viscoelastics or by the speculum. So release the speculum, make sure that the collecting bag is not having too much fluid. So evacuate it because it can cause traction of the speculum. And some wrong thing to do here is that when the surgeon is checking, seeing that the iris is coming out, that he will just inject viscoelastic. The viscoelastic will increase the intraocular pressure and cause more prolapse to the iris. So you need to release the intraocular pressure. That's what will help the iris to get in again. Conjunctival ballooning occurs also if the wound is more posterior or if it is more shallow, and this will result in that the fluid coming from the phaco-tip will pass under the conjunctiva. The solution here is very simple and very easy, that you will just make some scratches, some radial scratches in the conjunctiva by a sharp instrument like the MVR or the keratome. So this will release the fluid accumulating here. For the corneal complication, this can be the wound burn. What is the wound burn? You will find that the cornea becoming white, or the wound is becoming white and it is not self-sealing. It is becoming leaky wound. And why does this happen? This is because actually that the phaco is generating energy, that it is generating heat. This heat is cooled, or it is counteracted by the effect of cooling caused by the fluid which will pass within the sleeve. So this sleeve is coating the phaco needle in order to cool the phaco needle. So when does the wound burn occur? It occurs when you are doing phacoemulsification too close to the wound. So always try to be in the center, and always and also if the wound is too tight, so it will compress over the sleeve, or if the sleeve itself is too tight, so the fluid is or the cooling fluid cannot pass within the sleeve in order to cool the tip or cool the phaco needle. So this will be one of the complications that can occur to the wound or to occur to the cornea, resulting from the poor wound construction and the poor surgical technique. Another problem is called the Descemet detachment, and Descemet detachment can also has certain risk factors. For example, when the wound is when you are having blunt instruments, so the blunt instruments can result in a wound detachment or Descemet detachment. Also, if the patient has deep-seated orbit and the eye is very shallow, so you are entering into the eye perpendicular. This perpendicular entry into the eye when the eye is deeply seated within the orbit also can risk into the Descemet detachment. Also, poor surgical technique where you are hitting the back surface of the cornea by the phaco. This can also result in tears and detachment of the Descemet membrane. What will be the solution? Well, those patients will be having a post-operative corneal edema like that. Post-operative corneal edema like that, depending on whether it is peripheral or central and the amount of Descemet detachment, we can just either observe or can interfere intraoperatively by doing what's called desmatopexy or air desmatopexy. We can inject air bubble or inject gas such as sulfur hexafluoride that will tamponade this Descemet membrane and return it to its position. If the Descemet is totally removed or it is already eaten by the phaco, then we will need to have an keratoplasty. Regarding the anterior chamber, remember when I told you to ask in the history of the patients about the use of Tamsuline, which is an alpha-2 blocker used for patients with benign prosthetic hyperplasia. So this will result in what's called floppy iris syndrome, intraoperative floppy iris syndrome. In the intraoperative floppy iris syndrome, you can see that the iris tend always to get out from all the wounds, either from the main port, from the side port, making the surgical procedure very challenging. This drugs make the iris loses its tone. It will be flail, like flag. It will be like flag-shaped iris. It will lose its tone, so it will tend to come out from the wounds. What will be the prophylactic? Try to place the incision more anterior, try to make it more lamellar, like 3 steps. Also use dilated dilators like intraoperative phenylephrine or intraoperative adrenaline, or the use also of the pupil dilator ring or pupil dilating devices such as iris retractors or iris hooks. So this is for the intraoperative floppy iris syndrome. For the lens, we will starting from the rhexis, we have some complications could happen to the rhexis, like it could be a small rhexis like that. The problem with the small rhexis is that it will make the manipulation of the nucleus very difficult to come or to extract any part of the nucleus and get it out from this small opening, risking more of the damage to the anterior capsule and by the phaco or by the chopper, resulting in more incidence of complications. So the solution is very simple. It's just to make a snip into the anterior capsule edge and make a spiral rhexis, like to plan another rhexis to enlarge the smaller one. Because if you leave it, you can either have intraoperative complications, or you can even have, if you leave it and the surgery won't smooth, you can have post-operative complications like what's called capsular phimosis. It is a small contracted capsular opening, which will result in IOL dislocation and refractive error and astigmatism. So we don't want this. But even if this happens as well, we can do YAG laser cutting of the edges of the lens, edges of the anterior capsule. It can even be done at the end of the surgery by making a 2 releasing incision, like at 3 o'clock and 9 o'clock, to prevent this capsular phimosis. And even if you forgot to do this, you can do it by YAG laser later on. Large rexes also is not very good because you are making the IOL or the intraocular lens unstable. So an optimum size rexes of about 5 to 5.56 millimeter is optimal. Well, the most important complication is the extension of the capsular rexes. So you might find that there is running of the edge of the capsular rexes, resulting in the risk of that this edge may be running posteriorly, causing a break of the posterior capsule. How do we treat it? Actually, this is beyond the scope of this lecture, because this is like the how to manage a running rexes. This is like will take so much time to explain, and it is beyond the scope of the exam. If the patient, if you have a patient who had a white cataract, so you stain the capsule by the blue stain, you will find that there is a high intralenticular pressure, which may result in splitting of the capsule. So this will result in what's called Argentinian flag sign. So Argentinian flag sign, there is a splitting of the anterior capsule, which will result in which result from the high intralenticular pressure. That's why for those patients, you should aspirate first once you make the capsular opening in order to decrease the intralenticular pressure. And they also use cohesive viscoelastics in order to maintain the anterior chamber and try to flatten the lens. The capsular phimosis is a result from small rexes. Yes, capsular phimosis can occur due to many risk factors like fluid exfoliation and also small rexes. The next step is the complications regarding the lens and the capsule is during hydrodissection and hydrodrenation. This can result in what's called capsular book syndrome. Remember when I told you that you should evacuate a little bit of viscoelastics from the anterior chamber and try to remove this viscoelastics because you want to decrease the pressure in front of the lens, because when you are injecting fluid, if the pressure in front of the fluid is high, where will the fluid go? It will go to the area of weak pressure, or there is no pressure, which is the posterior capsule. So then this will result in that the posterior capsule or the capsular bag will be inflated with fluid, resulting in rupture of the posterior capsule with what's called capsular Brooks syndrome or capsular blowout. This will result in dropping of the nucleus into the vitreous. And how do we know this? We know this by what's called pupil snapback sign. If this happens, you will find the pupil will show momentary constriction during hydrodissection. You see the pupil will be showing sudden constriction. This means that the posterior capsule is open, and this was asked before in the ICU exams. It's called the pupil snapback sign. If the surgeon continued the surgery at that level and didn't realize that, this will result in dropping of the nucleus. So you have to be very careful. Here the surgeon realized that the pupil showing a snapback sign, so he is continuing the surgery as an extracapsular surgery. So he is removing it safely into the anterior chamber. Okay, let me show you it again for you to see the pupil snapback sign. So he's doing hydrodissection. Watch out now. You'll find the pupil will show sudden constriction. See it? Again. Now. So this is a capsular block, which will result in a posterior rupture or posterior capsule rupture. Okay, so Again, the lens complication, the most feared complication is the rupture of the posterior capsule. And again, the rupture of posterior capsule, to talk about the management about the rupture of posterior capsule, this will take us like a whole lecture. So this will depend on many factors, which stage you are now at the surgery, and whether the nucleus is soft or hard, and whether there is vitreous loss or not, and what will be the remnant in nucleus. Is there a quadrant or two quadrants or three or four quadrants are left? And what is your level of experience? So all these factors will control how would we manage a case of rupture posterior capsule. So the earliest thing or the most important is the early recognition. The earlier you recognize the posterior capsule break is the better outcome for the patient. And why we are giving too much importance for the rupture posterior capsule? Because it will change the course of the operation dramatically. So the good management of rupture posterior capsule will differentiate between a good outcome for the surgery or a poor outcome of the surgery. So let me just illustrate main points that was asked before in the exams. The problem of the rupture posterior capsule that you have two main problems, that the anterior hyaloid is breached, so there will be vitreous prolapse into the anterior chamber, and this vitreous prolapse will cause more incidence of retinal detachment and more incidence of cystoid macular edema, touch to the cornea, causing corneal decompensation, causing pseudophakic or aphakic glaucoma. So vitreous anatomically shouldn't be present in the anterior chamber. It should be placed into the vitreous chamber. So here we have after the break of the posterior capsule, the tension in the anterior chamber will drop. So this will invite the vitreous to come. So we want to minimize or prevent vitreous prolapse into the anterior chamber as much as possible. The other problem with the PCR is that another thing from above can sink down. So we have the vitreous come from down to above, and we have the nucleus fragment can sink from above to down. So a nucleus fragment can drop, resulting in that the present in the or the drop in the vitreous, resulting in vitritis, inflammation, and also high incidence of retinal detachment. So again, we want to prevent this from happening, and the key is early recognition. Like in the previous case I showed you for hydrodissection, if the surgeon didn't pay attention that he had a pupil snapback sign, he would have continued the surgeries and would have dropped the nucleus. So early recognition is the key. This is number one. The number two element is what happens if you have a dropped nucleus. This is a very common scenario in the exams. Would you go fishing after them? Would you just, with your phaco probe, you will just sink down and try to get it by your phaco probe and everyone is happy? Well, actually, no one will be happy after that, because you are doing a disastrous traction over the vitreous, which will cause very high incidence of retinal detachment. So the safest thing, if you have a dropped nuclear fragment, is just to leave it for a vitreoretinal surgeon to remove it via vitrectomy. So this will be the best outcome for the patient, okay? So this is very important for questions in the exam. Another important thing regarding the rupture posterior capsule is what will be your first response when you see the rupture posterior capsule. So when you detect a rupture posterior capsule, so you are doing your phaco, and you have your phaco, the second instrument or the shopper, and you realize that there is a rupture posterior capsule. So what happens if that the most surgeons will see the posterior capsule break? Oh, they will panic and they will remove the phaco probe and the shopper immediately. This is wrong. Why this is wrong? Because you will make the anterior chamber undergo sudden collapse. You are now removing the source of fluid which was maintaining the anterior chamber. So what happens when you are removing the source of fluid from the anterior chamber? That you are making the anterior chamber tension is low. What happens when the anterior chamber is low? Then this will result in you invite the vitreous. The vitreous will prolapse into the anterior chamber. So the break will extend and the anterior chamber and the prolapse of the vitreous will happen. Okay, so this is wrong. You don't do this. What happened, so what will be the safest method, or what is the safest technique in order to do when there is rupture of posterior capsule is what I'm illustrating now. So let's say that you have a rupture posterior capsule. So don't panic, just take just a few seconds or few minutes even to think. Then remove the shopper. This is the first thing to do. Remove the second instruments, maintaining the phaco probe within the eye and maintaining the irrigation on. So if you are doing vacuum, if you are doing ultrasound, just remove your foot pedal from step 3 or step 2 to step 1, trying to maintain the continuous irrigation. And while you are doing continuous irrigation, you inject the viscoelastics. So inject viscoelastics within the eye to form the anterior chamber so that you prevent the sudden collapse of the anterior chamber. At that level, you can safely remove the phaco probe. And this is how you maintain the break without increasing in the opening. You maintain the anterior hyaloid without being disturbed, and you prevent the vitreous collapse if it has not already occurred. Okay, so if it hasn't already occurred, by this technique, you minimize the collateral damage. It is so your mindset and during rupture posterior capsule is to minimize the damage as much as possible. If the patient has if I see a rupture posterior capsule, I want it to be only rupture posterior capsule without vitreous or nucleus drop. If I have a rupture posterior capsule with vitreous prolapse, I want it to be only rupture posterior capsule with vitreous prolapse but without nucleus drop. If I have nucleus drop, I want it to only be vitreous prolapse with rupture posterior capsule and the nucleus drop without incidence of retinal detachment. So you see that if at every step there is a goal to minimize the damage, and the better, the earlier you detect the problem, the better to prevent the poor complication or poor outcome. Okay. So this is very essential for your management of patients with rupture posterior capsule. So this will be the correct. Regarding the preoperative steps, please don't try, Dr. Mary, vitrectomy settings, please don't try to go through too much unnecessary details outside the scope of this lecture, because it will make, like, I know that you want to these details. It's asked in the WhatsApp group, but for others, they may hear this information for the first step. I know many of you may be phacosurgeons already, and they have like little information are missing, but for others, they may be hearing this for the first time. So if you are, I'm just overload you with information that is even beyond the scope of the exam. This will make them lose track of the important and essential information that I want you to be in your mind. So for extra information outside the scope of this lecture, please ask in the WhatsApp group, okay? For that, what are the important steps during the rupture posterior capsule? What should you do? First, as I mentioned, the steps of injecting viscoelastics and safely remove the phaco probe after injecting viscoelastic. As you do that, you are removing your foot pedal from step 3 to step 1, so that you are maintaining the continuous irrigation. So that's the foot pedal has 3 steps, like step 1, irrigation, step 2, vacuum, step 3, ultrasound, and you become on step 1. You are decreasing the bottle height, and this is very essential. Why you are decreasing the bottle height? So you are decreasing the bottle height because the bottle height is the source of irrigation. But you will say, but you told me that I wanted to have the anterior chamber maintained. So why I should decrease the bottle height? Because this high flow of the irrigation with opening of the posterior capsule will irrigate the vitreous, and this irrigation of the vitreous will cause more prolapse to the vitreous, resulting in increase the break and more vitreous prolapse. So we want to decrease the bottle height, like if it is like 100 to 10, it should be around 40 or 50, and decrease phaco parameters, like decreasing the vacuum, decreasing the ultrasound, and like if there is if there is any remnant any remnant nucleus part, and we wanted to remove it, then we need first to make sure that there is no vitreous, and then we inject viscoelastics and try to remove the nuclear matter safely with low phecoparameters. Okay, so these are how would we do in case of in case of rupture of posterior capsule. Another problem that could happen to the lens is zonular dialysis. Like if the patient has preoperative zonular dialysis, this can be detected preoperatively. You can see here that the zonule are missing here. So this one of the risk factors that you should look for preoperatively. Or it can happen intraoperatively. So you find here the bag is swept, like the bag is stripped from like 6 o'clock to 9 o'clock. So the bag here is not complete. So this is called the zonular dialysis, and this was also one of the complications that should be recognized intraoperatively. Otherwise, you are risking IOL dislocation or IOL drop. So how would we manage? This depends on the degree of dialysis. Like if it is between 3 to 9 o'clock, we put what's called capsule tension ring, or CTR. It can be either placed manually by like a McPherson forceps, or there are injectors that we can preloaded with this capsule tension ring, and this capsule tension ring will unfold and causing support to this weak area. So if it is like between only 3 to 9 clock hours, 0 to 3 clock hours, if it is between 3 to 6 clock hours of dialysis, then the other options is to do what's called Sioni ring or Ahmed segment. These are sclerally fixated. They have an eyelet. This opening is called an eyelet. And for the eyelet, this will result in that, well, these eyelets are fixed through scleral suture, so they can be useful for implantation, for support of the bag if the dialysis is more than 3 clock hours and less than 6 clock hours. But if it is more than 6 clock hours, then unlikely the bag shouldn't be used for support of the IOL, but we can use other methods for IOL support like iris fixated or like scleral fixated. Okay, so if we didn't pay attention to this dialysis, this will result in IOL dislocation. It can be dislocated into the vitreous like that, or it can be dislocated within the bag. So if it is dislocated in the bag, we need to also do, if we see it intraoperatively, we need to know what is the problem. If there is if there is dialysis, then it is not too late to put a CTR or Ahmed segment or Sioni ring. If the dialysis is very extensive, then this IOL should be explanted, and we would check for, or we need to implant another IOL, but either iris fixated or scleral fixated. And of course, it can be done on a second sitting. It doesn't have to be done on the same sitting. If it is anteriorly dislocated, this will be the easiest, so that you can just manipulate the IOL and return it back to the bag. But make sure that there is no dialysis and there is no vitreous prolapse, because vitreous prolapse also, if it is present, even if you are trying to dial the IOL and trying to put it in the bag or in the sulcus, it will not be in place. If there is vitreous here and try to push the IOL toward it, it will not go. Simple physics as well. Okay, so this is for the intraoperative complications. Now we come to